French cardiac surgeon Alain Carpentier's prophecy, the future of the cardiac surgery will be minimally invasive or it will not be. We convene today not merely as professionals, but as custodians of a transformative idea, a discipline where art meets engineering and courage meets compassion.
This assembly unites pioneers, practitioners, and prodigies from across Pakistan and beyond. Over the next 2 days, we shall not only dissect technologies and techniques, but we will also witness how smaller wounds yield faster healing and how quieter operating rooms produce louder outcomes. Now, in accordance with our tradition and to seek divine's guidance for our deliberations, we shall initiate this conference with the recitation of Holy Quran. May I invite Mr. Gulnawaz to come on stage for the recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين अल्लाह के नाम से जो बड़ा मेहरबान निहायत रहम वाला है। सब तारीफ़ें अल्लाह ही के लिए हैं जो तमाम जहानों का रब है, बड़ा मेहरबान निहायत रहम वाला, इंसाफ के दिन का मालिक है। हम तेरी ही इबादत करते हैं और तुझी से मदद मांगते हैं। हमें सीधे रास्ते पर चला, उन लोगों के रास्ते जिन पर तूने अपना फ़ज़ल किया, ना उन लोगों का जिन पर तेरा गज़ब हुआ, और ना गुमराहों के। सदक़ल्लाहुल अज़ीम।
To honor the soil and the flag under which we heal, I would request everyone to please stand up for the national anthem.
Now, to formally commence this conference, it's my honor to invite Chair of the conference, Professor Dr. Saeed Shakar Ahmad Shah, who is currently Dean and CEO of Peshawar Institute of Cardiology, to deliver the welcome address. Sir, may I kindly request you to come to the podium. Thank you.
Assalamu alaikum. On behalf of PIC, I welcome all my friends and colleagues, people who are coming from outside Peshawar. I also welcome a very distinguished friend of ours who's come from Oman today. And they're doing some the cardiologists are doing some fancy procedures as usual at PIC. So I welcome you, Dr. Al-Hassan. And we have a friend from Egypt as well, so they have some workshop going on simultaneously. There used to be an old saying when we were getting trained that the bigger the surgeon, the bigger the incision. And I think that thing has gone completely opposite now. I still follow the old principles. You know, my incisions usually are very big. And then there was another old adage where it said that you can't teach old dogs new tricks. But I see lots of old horses sitting over here that they have, mastered all these techniques. So things have really evolved. I have seen how cardiac surgery has evolved in Pakistan over the last 4 decades. Struggling with equipment, struggling with even getting patients from the cardiologist was a big struggle then. And alhamdulillah, now we see how cardiology and cardiac surgery has flourished in Pakistan, big way. And, as a cardiac surgeon, it's my instinctive inclination to, always support innovative surgeries, and whenever you guys want to bring in cutting-edge technologies, I think as administrator as well, I will always support that. And I think that's part of our professional duties as well as surgeons. I think that's the trust we have with the society, that whenever new techniques come in, we provide access to the general public and offer them affordable and latest techniques. So I'm so happy that, at such a major conference is being held at PIC. So I think over the last 2.5 years, this is the second major cardiac surgical conference in Peshawar. We had the 12th biennial here in 2023. When you introduce something, a new service or new procedures in a hospital, it does have several challenges. All these new procedures come with a cost, and I think that is one of the major factors that affect us in public hospitals. And you have to decide whether you can justify allocating so much money for these new procedures when you have long waiting lists and your conventional procedures cannot be covered, and most of the patients, especially on the surgical, are suffering because of the long waiting lists. But it does bring, it raises the profile of the hospital where these procedures are being done. It distinguishes these hospitals from other hospitals. And I think as I have gone into administration, we took it upon ourselves that we need to bring Peshawar Institute of Cardiology at a level and provide services which are not being provided elsewhere. And then you had noble intentions, but then you had to get the money as well. And there is only that much pie, and there are so many people who want to put their hands in that pie. So every second day, Haji Saab, who is Dr. Tariq, has just done his Hajj, so we call him affectionately Haji Saab, comes into my office with lists of instruments and equipment. And then next day, then we have other power brokers and power centers in the hospital, our interventional cardiologists and our structural heart cardiologists, and they come in and they say, well, these are the new fancy valves and only cost 6 million rupees, and then the pediatric cardiologist comes in. So, you have very limited pie, and you have to satisfy everybody. So, one of, the financial challenges that we had, we decided from the start that though as an institution we'll help to start these fancy procedures, but sooner or later they will have to generate their own funds. And the idea was to do a few of them initially so that you build up credibility among your local population and start getting referrals. So we decided, when we started doing TAVIs here, we got the board to approve free TAVIs for the first 5 cases. And we did the first one and advertised it a bit. And next 2 patients came from Aga Khan, referred from Aga Khan, and they are all paying patients. We never ever spent that money that we allocated. And all the patients who are coming in now are self-paying patients. Same thing happened with the minimally invasive cardiac surgery. We initially invested some money. And because the hospital has a good name and the surgeons have good credibility in the community, all those people who could pay, they just started coming in. So we don't have to actually pay a penny for these procedures as well. So I think that was one of the ways that we introduced these very complex, high quality, very expensive procedures. And we made sure that that little 1% of the population that exists in Pakistan who can afford to pay will come to us and get these procedures done. It does stress our hospital. You know, the supply chains get affected. We have been trying to standardize our operations. We have been trying to standardize the equipment, the suture material, disposables, so that everybody does it the same way and we have a limited inventory. So when you bring in these new procedures, you actually strain that system. And, you know, I have to be on the right side of my director of finance because the minute we start spending too much money in, he plugs the source and he says, we don't have any more money. So our faculty doesn't realize that, but I'm fighting for you guys all the time with my administration. So you guys have been doing super job, and not only the faculty, but our administration side as well. Do I have a few minutes or? I have? Okay. Well, I'm just going to digress a little bit and just come back to our association. Being the president, the new president of the Pakistan Association of Cardiothoracic Surgeons, when we came in, we had issues with the association. There were governance issues and burning issues which had not been settled down. So during the last 6 months that I've been the president, we have tried to streamline. We have tried to make it a proper organization. So we've brought in policies, regulations and policies. We have established a proper website and a proper communication channels so that the members can communicate officially through proper emails. We are going through a very difficult time at the moment. Our first task was to be able to hold the executive council elections so that then we have a representative body which can take decisions. So during that interim period, there's most of the senior surgeons that we have, many of them are sitting over here. They volunteered and they joined our advisory council and they've been advising me on different issues. But sooner or later, the sooner we get our own executive council, the better it is. And Shahid Sami is doing an excellent job, and I think we are on the cusp of conducting these elections. And once we have the executive council, then we'll sort out the governance issues as well. So let's see. I think there are difficult but exciting times ahead, and then I'll pass on the torch to the next president, and then they can complete the task. So I once again thank all the delegates. Thank you, our friends from Oman and Egypt. You guys, given us a great pleasure that you are here. And I also take this opportunity to thank our organizing committee, especially Dr. Tariq. You have done a wonderful job. Saad, you have done a wonderful job. And all the other organizing committee members to make this a successful, hopefully it will be a successful conference. So I wish you the best. Thank you.
Thank you, sir. Respected audience. The best way to find yourself is to lose yourself in the service of others, says Mahatma Gandhi. to trace the arc of evolution and future directions of the minimally invasive cardiac surgery, and to set forth the objectives of this conference, please welcome Dr. Muhammad Tariq, who is Associate Dean, PGME, member of the Executive Council of PGMI, Head of the Cardiac Surgery Department, PIC, and the Principal Convener of the conference. So please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. First of all, I would like to thank each and every one of you for coming up and traveling all the way to Peshawar. Once again, though in 2 years' time, but we will be calling you again and again, inshallah, in the future as well. When I came back to Pakistan, this was always in my mind, how to excel further and keep challenging yourself. And this was one aspect that was broadly, largely missing in cardiac surgery in Pakistan, in maybe 5, 6, 7 years back. Then, blessed with the opportunity, came to PIC, and then started working here, initially the normal routine open heart work, and slowly and gradually then started thinking of switching gears and getting into something more complex, futuristic, advanced skills and all that. And then we started off with simple minimal invasives, but the idea was to let the program flourish and grow. In that, I would especially thank my colleagues, my seniors, who helped us out in this journey. Professor Parvez Chaudhary is here. My mentors, Dr. Asnad, Dr. Sami are here. Yasir, I have been seeking guidance from. Mangi, my dear friend, he has always been a helping hand in that. And then the next thing was to gather these surgeons who are doing mix across Pakistan on a platform, actually. So this was the whole idea in having this gathering for today, to have all the very precise group of mix of surgeons who are doing mix. And then the future will be probably to let others help. And tomorrow, the whole day is dedicated towards teaching and live cases and all that. So those who are not doing it, or who are, shying away, or maybe having some reluctancy, we can guide them through tomorrow's live sessions and the sessions to come in the future. I would just take one more minute in just suggesting that we all work as a close group, because it's a very small group of people who are doing mix across Pakistan, and work hard so that it can be, a norm one day in Pakistan, and everybody or every center shall be having some mixed procedures going. It's an evolution of cardiac surgery. We have our seniors, mentors, and our, they carry on, and the history, and they actually were the ones who, took the history over and were trained in era where things were very, at their very meager facilities and, low levels. But they have taken this to new heights, actually. And we will be seeking their guidance and taking this for the future as well. I just have a small clip to show how things have evolved in every field, in technology and in medicine as well. And then I'll just hand it over. So just lastly, everything evolves, whether we accept it or not. It's today or never. I hope these 2 days will be full of knowledge, sharing skills, and sharing our thoughts about the future of cardiac surgery and more focusing more on minimally invasive cardiac surgery. Thank you again for showing up and coming all the way. And I hope you all have a good time in the next 2 days. Thank you.
Now, ladies and gentlemen, before we begin with the scientific sessions, we will first invite our esteemed panelists to kindly join us on stage. May I invite Dr. Shahid Sami to please join us on stage. May I also invite Dr. Parvez Chaudhary to kindly come forward. I would like to request Dr. Hasnat Sharif to please join the panel. And may I finally invite Dr. Niaz Ali to complete the panel. We sincerely appreciate their presence and valuable expertise. With that, we will now proceed to session 1, Advances in Minimally Invasive Valve Surgery. For this session, I would like to invite Dr. Ali Raza Mangi. He is a renowned cardiothoracic surgeon and professor of cardiac surgery at NICVT Karachi. He has extensive experience in adult cardiac surgery and complex cardiovascular procedures. He has also a keen interest in minimal invasive and keyhole cardiac surgery procedures. Sir.
Thank you, everyone. So, I'm Dr. Ali Raza from NICVT, and I hope the more experienced surgeons, like my teachers, Dr. Parvez Chaudhary is here. He will tell more about it. I'm starting with the advances in cardiac surgery. So, nothing to disclose except my hospital, NICVT. So why minimally invasive now? Just because of the patient demand, and patient demand because of the advanced technologies involved, faster recovery, less pain, and better cosmesis. Evidence, has been proved that the comparative mortality to the sternotomy and other cases. System benefits because of the shorter stay and the shorter length of stay in the hospital. Patient has the reduced transfusion rates, so the patient early return to the work, this is more important. Constants, there is a learning curve and equipment cost, and definitely it is based on the case selection. So, have you used these gadgets in your past? Where are they today? So, if you stay out of the focus, then you are the out of business. And now this is this. Evolution timeline, every decade after the 1990s, the minimally invasive cardiac surgery has evolved. In 1990s, the port access CABG was started with the minithoracotomy and AVR was started. It has again revolved after the 10 years. In 2000, when the robotic telemanipulation was started. And the Da Vinci has started the robotic assisted CABGs. 2010, total endoscopic CABG was came into the market with the use of telescope, exoscopes, and sutureless valves. In 2020s, the uniportal valves, hybrid procedures, and 3D exoscopes came into the market. So access approach, mainly the right anterior mini thoracotomy is used for the mitral valve, aortic valve, and the double valve. The lower hemisterectomy mainly used for the AVR and ascending aorta. Left mini thoracotomy is used for the lima harvesting and for the MIDCAB. Uniportal VATS is used for the mitral valve, tricuspid valve, and the double valve. So robotic 3 to 4 arm ports are commonly used in advanced centers. They are using it for mitral valve repair, ASDs, and also for the cabbage. So mitral valve surgery, the right mini thoracotomy, it is the gold standard for the mitral valve repairs. About 95% of the cases in the developed centers, like in Germany, where I have worked in the German Heart Center Munich, they are only using these approaches for the mitral valve repair cases. The key technologies involve the 3D endoscopes, CO2 field insufflation. Transesophageal guidance is more important because without transesophageal guidance, you will not be able to see the repair. Intra-aortic occluder devices are commonly being used. Custodial cardioplegia has came into the market, and they have started the one dose is enough for the 3 hours. So this is the evidence based that custodial cardioplegia, single dose, you can do your work for complex cases, or you can do the minimal invasive procedures up to 3 hours. Aortic valve surgery. The upper hemisterectomy commonly used for the direct vision, and the right mini thoracotomy and cosmesis is suitable for the sutureless valves, pericardial valves, and it has come into the market because of the rapid deployment of the valve, which has decreased the cross-claim by 30 to 40% time. TAVI versus minimal invasive AVR. Evidence has proved that surgery is more beneficial in cases of bicuspid valve and concomitant pathology. Coronary artery bypass grafting. The advanced technology has started like MIDCAB and lima to LAD, mainly through the left thoracotomy, and the TCAB is commonly being used in advanced centers. We are not using in Pakistan because of the gadgets are so expensive. So mainly it is being used in developed centers. Their hybrid procedures are more coming into the market. They are doing is the lima to LAD is for the surgeon, the rest of the lesion being addressed by our cardiologist guys. They are doing the PCR. Patency rates are equivalent to the conventional cabbage at 5 years. Data is not showing more than 5 years just because we have evolving over the procedures. So advances in these procedures came into the market just because of the advanced technology, like harvesting 3 for the proximal anastomosis, coronary 7 for 7-0, distal anastomosis. So technology enablers are because of the 3D endoscopes and the exoscopes. Robotic wristed instruments work up to this 7-degree freedom. And peripheral perfusion cannulas are being more invented with the use of femoral arterial and venous cannulas. Aortic balloon occlusion or transthoracic clamp, they are being commonly used. Initially, people were using the Chitwood clamp. Now they are using is flexible clamps. So 3D printing is necessary for your preoperative planning before you are going for a valve repair or before you are going for the valve replacement. Mortality is about 0.8 to 1.5% as compared to sternotomy. And transfusion rates is 15 to 30% reduced as compared to conventional cabbages or conventional procedures. Length of stay is 4 to 5 days versus 6 to 8 days in conventional cases. This is our result. We have done the minimally invasive double valve replacement in which we have operated around 19 cases, and we found the shorter length of stay, shorter ICU stay, and the patient satisfaction. So excellence has a price. So if you want a Mercedes, you have to pay Mercedes money. You cannot get it for the cost of Alto. So capital cost is always involved in these gadgets. Capital cost for the endoscopes is about 80,000 US dollar for the endoscopes. As compared to the robotic arms, they cost about 2.5 to 3 million US dollar. Per case cost involved is about 1.2 to 3,000 US dollar for the endoscopic instruments and balloon clamps. So OR setup, peripheral cannulation PIC, we are commonly using here in Pakistan, and CO2 insufflator and long shaft instruments. These all are being manufactured in Pakistan. So that's not a big problem. Team dedicated perfusionists, trained skilled nurse, anesthesiologist should be familiar for the single lung ventilation. Return of investment is you can achieve by the reduced length of stay is about 1.5 days, which offsets the instrument costs after 150 cases per year. So why not we are using these advanced gadgets in our cardiac surgery while robotic surgery is being commonly used in other procedures in Pakistan? It's a one-time investment. Definitely it involves a learning curve, but it is possible. People are using it. I have done few cases with the robotic assisted cabbages, and it is very easier as compared to we are doing it the direct vision. Robotic arm, Da Vinci, it involves the four instrumental arm plus 3D camera with a 7 degree of freedom, motion scaling with the tremor filtration, and best for the mitral valve repair, ASD closure, and selective cabbage. Cross clamp and aortic balloon are the transthoracic clamps. These are commonly used with the robotic assisted cabbages. Multiple patients are being referred outside of Pakistan because of non-availability within the Pakistan. So if you are not affording this robotic arm, then second chance should be the endoscope, which involve the 3D SD camera, long shafted instruments, which we have already, direct manual suturing through the 2 to 3 centimeter incision, and lower capital cost with a faster setup than the robot. Hurdles of the minimal invasive cardiac surgery which we are facing in Pakistan are the pain, which can be resolved with the use of cryoablation, which temporarily blocks the nerve for at least 3 months. Cost, it's a reduced length of stay, early recovery, and lesser cost than the robotic or endoscopic surgery. And most commonly, we can cover the cost with early return to the work. Patient can earn more. This is the evidence shows that the minimal invasive cardiac surgery has a reduced length of stay in the hospital, and patient go early to the work. So advanced minimal invasive cardiac surgery has equivalent outcomes and better outcomes. With the mitral valve repair is the strongest condition worldwide, strongest indication worldwide. Success hinges on the case selection and the team experience. Hybrid strategies are expanded and for the eligible pool. So future direction should be the AI-guided instrument tracking, smaller robotic platforms, and endoscopic aortic surgery, fully percutaneous surgical valves. The Saudi has performed first robotic pump and first heart transplant through robotic assisted. So why can't we cannot do? So, evolution taught us that adaptation is the key to the survival. Any question?
Any questions?
Yes, Dr. Farid. Yeah, yes.
system.
Da Vinci system. Da Vinci is a microport which is being used here in Lahore.
Yeah.
It is the same configuration as the Da Vinci. And a majority of the Da Vinci technical members are the part of this microport.
And you did it with bypass or off pump?
I did bypass.
Thank you.
Thank you, sir.
Thank you. Who's the next? I think we have seen the progress of cardiac surgery, just like the progress of Homo sapiens. We have gone through the Stone Age, to Iron Age, to Industrial Age, and now the Computer Age. I think that the Stone Age of cardiac surgery was when one of the great surgeons said that heart is an untouchable organ. To Iron Age, when the Gibbon made the machine and it became possible to operate on the heart. To Industrial Age, when Favaloro in '67 started doing coronary artery bypass graft. To now Computer and Technology Age, when we can do minimally invasive surgery on the heart. And this evolution is there for us to adopt. I think that in Pakistan the time has come, like in many other countries in the world, that we have to build subspecialties. There are centers in USA, in UK and Europe who specialize in doing aortic surgery. There are centers who are doing minimally invasive surgery. On the other hand, gradually the coronary artery bypass grafting has taken shape as a subspecialty. The same is true for congenital heart disease. So I request all the young surgeons to please focus on these new technologies and specialties. And in Pakistan, administrators like Professor Shakar, who is sitting here, to make and work towards center who specialize in one particular specialty, like MICS. And if Peshawar wants to take a lead in that, that is a very good thing, that they can hold workshop for new surgeons, for our younger generation, to teach these things, have workshops, simulators, and other things. Thank you.
Thank you very much. Can I make a few comments? I think the reason why we have survived as a specialty is because our forefathers were very much involved in the registries. Everything that they did or did not do, they put it down, and it was open to scrutiny. I think as we progress into this new era, we will be at our best if we keep the registry and look at our outcomes. I know Ali talked about 5-year outcomes. The issues come after 10 or after 15 years. So we need to continue to have meticulously tracking of our data. The other issue is going to be about value. We talk about cost, we talk about quality. If you combine the two, you then have value, and then, like Ali talked about it, it's the patient satisfaction and patient-reported outcomes that become important. So I think that's what tells us what the society wants. Like Dr. Shakar said, big surgeons used to make big surgeons, used to make big incisions. Things have changed. The society has changed. And we have to change, otherwise we'll become the dinosaurs of the past.
I will touch another aspect. Professor Shakar is here, he is the president. I think we are lacking our own data, our own registry. If the society can work for it, and we in Pakistan, we can make because a lot of surgery is done, we can make our own registry, and then we can look at our own data. Because always when we are quoting, it is from the outside. So I think that will be, society can look for it.
Can I add over there? I think I've been working on this. We will, inshallah, on the website give a link to this. I've talked to Shakar about it. We've worked extensively on it. We've looked at it in a smaller model, but I think hopefully we should be able to give a link on the the web page, and it should be then available for free for all institutions, not as a paid service. I know Dr. Asim is here, he's looking very attentively at this. We've talked about this, and Asim, we will work together to bring this to fruition.
I would like to congratulate the entire team who have developed this, Dr. Tariq. Oh, but Bakar, Dr. Shakar. This is actually formally first minimally invasive conference in Pakistan. We have had other conferences and we have had the talks in it. Some people have even tried to do minimally invasive, who themselves were not doing it. This is the first time the center is doing it, and all the speakers, everybody involved. So congratulations. We had a good night's stay. We are well rested, and we'll make some changes. Only thing I will request from the audiences, even if you don't believe in it, even if you have had a bad experience, now you have chosen your time to be here. At least have your mind open that where is it heading. और लतीफ़े के तौर पे मैं बचपन में चौधरीयों पे पैदा हो गए, तो बचपन में मैं आपको पंचायतें भी करता रहा हूँ गाँव में। तो हमारे गांव में 6 टांगे वाले थे। वहां पे आके एक रक्शे वाला खड़ा हो गया। अब वो रक्शे वाला जब तक वो एक चक्कर लगा देता, वो 3 लगा लेता था, पैसे उतने ले रहा था। तो वो सारे टांगे वाले मेरे घर आ गए, सर जी इसको कहें कि ये हमारे साथ नंबर में लगे करें। मैंने बोला उनको क्या कहा, बेटा टांगे बेच के रक्षा ले लो। Technology you cannot stop. हमारे ancestors ने पत्थरों से अपने डिफेंस के, किसी ने कुल्हाड़ा बनाया, किसी ने कुछ बनाया। अब लोग ट्रंप से डर रहे हैं न्यूक्लियर बम न मार दे। तो जो पहाड़ों में रह रहे हैं वो तो नहीं उसके सामने सरवाइव कर सकते। कार्डियक सर्जरी बाय इटसेल्फ इन अमेरिका, खैर पाकिस्तान में तो सब चलता है। इन अमेरिका you still, if you're going to do TAVI, 2 surgeons have to see the patient and say that is a high risk. Or now they are starting to do it the middle risk because technology has taken over. You do TAVI, 5 years later it's not working. You can fire a valve inside the valve. So cardiac surgery is becoming a dying field because कुछ भी नाम करें, एक AST कर दे, AST कितना प्रोसीजर है। Sternotomy can destroy a person's life or even a family. No family has 3 months. Well, rich people, or if you are a general in the military, most people, 60 to 70% people we do, don't have 2-4-6 लाख पड़ा हुआ बैंक में कि उनके 3 महीने चलते रहे, बच्चों की फीस भी वही रहे, खाना पीना भी वही रहे, और फिर वो वापस जाए तो उसको वो जॉब भी मिल जाए जब उसके सामने इतना बड़ा शिकार हो। यहाँ तो मेरे पास अभी पेशेंट है जिनकी मंगनियां टूट गई क्योंकि उनकी स्टेनोटॉमी हुई। So heart surgery is heading there, that because this is our first job, that what benefits the patient. And second thing we always think is it reproducible? तारक कर रहा है उधर, वकार कर लेता है कभी, 2 परवेज ने कर दी है, then we are not picking something. ये robot Robot will not come into the third world. Okay, government centers, they may be able to afford it, few. But just like Dr. Shakar said, unless the department is carrying itself, nobody can feed you and keep you alive. You can't tell them that हमारा कुछ 40-50 लाख पर केस आ जाता है अगर अगले साल का कैलकुलेट करें और रोबोट की प्राइस उसमें डालें। वो कहते पापा वो 2 लाख में कर रहे हैं, तू 50 लाख में क्यों कर रहा है? So we will catch up with it as the technology becomes cheaper. We are still doing things by washing disposables. Because if we use all disposables once and throw them out, you won't see any private program in Pakistan. Nobody couldn't be able to afford it. So thank you, and just keep your mind open. Thank you much.
अस्सलाम डॉक्टर परवेज़। मेरा नाम डॉक्टर फरीद अहमद चौधरी है सर। मैं कार्डियक सर्जन हूँ रहमतुल्लाह आलमी इंस्टीट्यूट ऑफ कार्डियोलॉजी में। वी हैव बीन डूइंग मिनिमल इन्वेसिव सिंस 2018. So we have been doing double valve, mitral valve, aortic valve, scabbage, and now we have invested in microport robotic system, and we are expecting to get that robot in next 2 months. But the problem is that their microsurgical instruments have not yet been FDA approved. So unless they have the microsurgical instruments will be FDA approved, we cannot import them. So Dr. Mangi is lucky that they have this Da Vinci system who has already been approved, and they got the microsurgical instruments and they have been able to perform the CABG. My addition is that for the young surgeons, our first intention is to do a complete surgery rather than a fancy surgery. I don't mind doing sternotomy at all. If we have like 4 grafts, 5 grafts, and we cannot do it minimally invasive, so we should not opt for it. So far we have achieved is that the cases which we have done, we strictly remain into 5 centimeter incision. So I'm not in a favor of doing a large anterolateral thoracotomies or large posterolateral thoracotomies rather than avoiding sternotomy. Sternotomy is not a stigma for me, neither for my patients. If we should be able to do a minimally invasive as a minimally invasive, then it's fine. Otherwise, sternotomy pain is much more than the thoracotomy pain is much more than the sternotomy pain. So my advice to my team is at least that our first option should be to do a complete procedure, and second option should be to do a fancy procedure. That's how we can maintain the results. We can maintain the trust in the cardiac surgery of the people. Now, cardiac surgery has flushed to next level. People have faith in cardiac surgery. लोग बचते हैं, लोग अच्छी लाइफ गुजारते हैं. But just to get into a minimally invasive and then start absorbing high mortalities or suboptimal results should not be encouraged. That's my idea, sir.
Anybody wants to tackle the question, or should I talk about it? We are running out of time. I have a talk at 2 o'clock. I will address those.
Respected audience, the old master taught, measure twice, but cut once. This is being encountered in the session of minimally invasive coronary revascularization. To present how this principle executes on the beating heart, it's my privilege to invite Dr. Yasir Hakwani. He's a consultant cardiac surgeon at CPH Multan with over 15 years of experience in the field. He's also known for his expertise in minimally invasive heart procedures and keyhole bypass surgery. Sir, please.
जी बिस्मिल्लाहिर्रहमानिर्रहीम. Thank you very much. Yes. Thank you very much for giving me an opportunity to come here and speak. And also, I would like to congratulate Professor Shakar Saab and Dr. Tariq for organizing such a wonderful minimal invasive first minimal invasive conference here. Before speaking about the technical details of how to perform a minimal invasive multi-vessel coronary artery bypass grafting, it would be quite unjust if I do not acknowledge the services of Dr. Parvez Chaudhary here. Means it was 5 years back when we started this program. It was in Multan. And in those 5 years, we've established the programs and we have done more than 300 multi-vessel minimal invasive CABGs. This is apart from the valves, ASDs, VSDs, and the other procedures. And I still remember that for this program to run, we especially asked Dr. Chaudhary to come up at our center and help us in establishing this program. I would talk that how we established this in detail in the upcoming slides. Thank you very much. So, it was the 1 year follow-up I discussed in the last Karachi meeting of over 200 patients. And I also had the opportunity to present this data in Belfast this year of the follow-up of 1 year follow-up of our patients, the objective data, how the patient is feeling based upon the SF12 questionnaire. So this is how we modified our techniques, and this is how we established our minimal invasive multi-vessel coronary artery bypass graft surgery. So this is our city, Multan. So why this matters? The question is, minimal invasive CABG, aims to deliver the surgical durability with less excess, particularly attractive for Lima to LAD and non-LAD multivessel disease. There are some patients who are not suitable for multivessel CABGs, then we offer them the hybrid revascularizations. There are selected patients who are desiring sternum preservation. As we're just talking about the sternotomy. So the question arises, is it about the incision of 5 centimeters, 7 centimeters, 8 centimeters? Probably in our country, in our society, it's not at all about the incision. It's about early return to work. So by doing the minimal invasive procedures, we are offering the patient to early return to work. This is how we are going to lower the cost of the patient, lower the cost of the procedure, and also to ease the burden on the society. So the potential advantages we've already discussed. This is less wound morbidity, faster mobilization, shorter length of stay, and better cosmetic results are also seen. What are the main barriers? When we were talking of keyhole heart surgery or minimal invasive heart surgery, so this is the main barrier is the exposure. So we have got a very limited exposure from where we are going to perform these 2 grafts, 3 grafts, or sometimes 4 grafts. So the exposure is of key quality. So you must be having the incision in the right space and having the right amount of pericardial stay sutures so that you can bring the heart and the vessels in front of you so to have a very good exposure. Secondly, the learning curve. The learning curve is very important. Means if you're in the initial practice, so I would suggest that you must do initially single graft patients. And when you're adept in doing more than 20 to 30 multi-vessel cabbages, then probably you are in a relatively safe zone. And the team dependence. So this is one single important factor which you must understand. When you're going to establish a center, the team is very important. So what happens that we have seen that in the many institutions, your team doesn't remain the same. Means आपने एक nurse को, you have trained the nurse, the scrub nurse, in doing the peripheral cannulation in the last 4 years' time, and sometimes it happens that she's got married and she went away. And you have trained a perfusionist in doing doing the vacuum drainage and decompressing the heart sometimes, in doing the, for example, valve surgery. So sometimes you see that the perfusionist is away. So the team dependency is very important. So you must have an alternative team always available, and you must train all those, the team members, your assistant surgeons, your scrub nurse, your perfusionist, your operation theater attendants as well, who look after the instruments. So this is how the success of the program happens. Multi-vessel minimal invasive CABG remains technically demanding and depends heavily on the operative planning and exposure strategy. So there are the different types. So number one is the MIDCAB, then the mixed CABG, multi-vessel minimal invasive CABG through the left mini thoracotomy can address the LAD, diagonal, OMs, PDAs, PLVs in selected cases. And it can be performed both ways, on pump and off pump. So in our personal perspective, personal viewpoint, so pump is not your enemy. You're always at the ease of using the pump. The goal is to do the complete revascularization, to do a very good quality of the anastomosis and a very good quality of the graft, rather than leaving one single graft or doing a bad grafting. You can always have the pump available by your side. Or otherwise, you can go for a hybrid revascularization. Surgically, you perform the Lima to LAD, and you can do the PCI to the non-LAD lesions. So the important point is that not all the minimal invasive CABGs are the same procedure. What are the best early candidates? Non-obese or moderately built patients, patients who are having a good pulmonary reserve, who have got a favorable CT anatomy, target vessels with a usable caliber, and non-calcified aorta if the proximal work and the proximal anastomosis, they are anticipated. So the ideal coronary anatomy are the good LAD target, diagonal OM accessible from the left thoracotomy, and the favorable heart mobility. And one other thing I would means from my own personal experience, I've come to know that the patients who are known COPD patients, they've got a good barrel chest. So probably they give a very good exposure to do the minimal invasive MIDCAB. So what are the good indications? Isolated LAD with additional PCI-able lesions, multivessel disease with favorable lateral wall targets, reduced sternotomy avoidance in selected patients. A patient who has already been undergone some valve procedures initially, so you can always go for from a thoracotomy, which is always a virgin area in those patients. So what are the relative contraindications? In our society, in our population, we see a lot of intramyocardial LADs. So if you're suspecting from a very detailed view of the coronary angiogram, if you're suspecting an intramyocardial LAD lesion, so probably that's not a very good case to go with in the initial learning stages. Diffusely diseased tiny vessels. So any vessel, if you're suspecting less than 1.5 mm, so I would rather suggest in the initial days you should restrain from doing that minimal invasive. Spare chest wall deformity, some pleural adhesions, or hemodynamic instability if you happen to have hemodynamical instability in the initial phase. So or the poor LV reserve in an inexperienced program. So what in our own center, what we have done a criteria, any patient who's got an ejection fraction of less than 35%, so we try to defer them from the minimal invasive MIDCAB. A completely intramyocardial LED is a major technical limitation in classic MIDCAB because conduit length and target exposure becomes problematic. So you have to review the coronary angiogram very carefully initially before going into the OR. CT chest if concerns about the anatomy, aorta, calcification, adhesions, or the conduit course. You must have an echo for LV function and valvular disease. Define strategy before the skin in CN, off pump versus on pump. You should have a clear program and have a clear plan in your mind before going into the OR. What number of target vessels are you going to perform? The conduit plan. The sequence of grafting is also very important. You should have that in mind before going to have the surgery performed. And also hybrid versus fully surgical mixed cabbage. You always have to ask 4 questions. What are those 4 questions? Can I reach all the intended targets safely? Which conduit gives the most reliable geometry? So geometry of the conduit, the lie of the conduit, the length of the conduit, that is very important. Means we have seen many times that I've performed a bypass graft, it looked very good, it was very fine, but at the end of the procedure, I saw there was a little twist in it because it's very difficult from a very small incision to have the correct geometry of the graft to understand. So that comes with experience. Will hemodynamics tolerate the exposure? And what is my bailout plan? This is very important. You should have that in mind before going to the OR. If the anatomy is not convincingly favorable, convert the plan early, not late. So conversion, that's no harm. You can always convert, but convert early. If you're having difficulty, convert early. There's no harm in converting into an open procedure rather than doing it minimally invasive, and when the reserves of the heart they are completely replenished, then that becomes difficult for the heart to come back. So anatomical features favoring the MIDCAB. Slim patients, thin tubular vertically positioned hearts, non-calcified mid-distal segment 2 to 4 centimeter distal to the second diagonal branch LED, arterial diameter greater than 1.75 in diameter, they are the ideal vessels, and total occlusion of the LED with good collaterals to the distal segments. So because they tolerate the ischemia very well. And what are the angiographic details impacting the decision making for the MIDCAB? LED course, whether it reaches the apex or falls significantly short of it. LED depth, epicardial or deep intramyocardial. LED wall quality, diffusely diseased calcification is there, or it is a diffusely diseased vessel. LED stenosis. Higher the grade of stenosis, better is the tolerance to occlusion. Location of the accompanying arteries, a large diagonal running parallel to the LED may be mistaken for an LED and be grafted. Position of the stents if the artery has already previously been stented. That too is important. So what operating room setup are you requiring? A rehearsed team is important. DFF pads, TOE should be available, groins should be prepped, external pacing pads should already be applied, coronary stabilizer and positioner already ready, shunts should be available. The patient position is 30 degrees, right lateral, and the chest should be slightly elevated. Left chest elevated, left arm tucked or positioned to open the intercostal space. So these are the very finer details which are very important, because if you are going to get even a small millimeter or 2 millimeters of extra exposure, that is going to help you in performing the surgery easily. Otherwise, you're going to struggle, believe me. So this is the exposure, and this is how we give incision. And the planning of the incision is very important. Either you are going to go from the 4th space, 5th space, means proximal to the nipple, below the nipple, lateral to the nipple. So this is very important. That planning comes from the detailed angiographic view, and secondly, from an X-ray chest. Sometimes CT might be needed. So typically accesses from the fourth or fifth intercostal space. The incision choice depends on the body habitus, LAD location, whether only anterior or lateral inferior wall targets are planned. So this is how we are going to plan the incision. What are the technical goals? This is the single very important thing. The lima should reach comfortably. It shouldn't be stretched. It shouldn't be in tension. Visualize the LAD very well. Do not misunderstand it with the large diagonal branch, and preserve the rib integrity where possible. So we have always seen in in the last 5 years experience, as soon as the rib is broken down or the costal cartilage is broken down, the harvesting of the lima, that becomes very difficult. So always try to remain, to keep the rib integrity wherever possible. What are the helpful maneuvers? Soft tissue retractor, the use of soft tissue retractors, that is going to help you a lot. Low profile rib spreader is very important, because if you're going to get a few millimeters of space extra, so that is going to help you in performing the bypass grafting. Divide part of the costochondral cartilage only if absolutely necessary. Pericardial traction sutures, they are very important. And one important thing is that you have to take control of the aorta. If you're able to encircle the aorta and pass a tape behind the aorta, then you are in the very safe zone. Poor incision placement causes most early frustration. Place it for the distal work, not just for the entry. So this is one of our cases. The LAD is clearly visualized, a big vessel, 2 millimeter vessel. The lima is there. So lima is the cornerstone. Lima to LAD remains the anchor graft. The harvest options are either the direct harvesting through the thoracotomy or through the endoscopic approach. Wide exposure of the memory bed is very important. Careful hemostasis is important. Avoid thermal injury. Harvest adequate length to avoid tension, and open pleura strategically for reach. The key point is that you are always going to open the lima retractor sequentially, bit by bit. Initially, when you are going to open the lima retractor, you are going to see only the distal end, and one sees that it's very difficult because it's not going to open. And one maneuver, we call it as a buckle handle maneuver, because if you place the retractor in the middle graft, in the mid of the rib, from away from the neck, in the mid portion of the rib, that is going to spring open the chest with a wide exposure rather than on the extreme lateral or the extreme medial side of the ribs. Open the pericardium anterior to the phrenic nerve. Suspend the pericardium with traction sutures. This is one single important thing. If you are going to perform the pericardial sutures well, so you're going to get the heart all in front of you. So that improves the anterior exposure. Rotate the heart for a lateral wall network. What we do, we always perform some deep pericardial stay sutures for sometimes the PDA graft and also for the lateral graft. So reduce the lung interference. Identify the LAD, diagonal branches, OM branches, and posterior targets, only the highly selected cases. Use pre-op angiogram mentally in 3D, target depth, course, and relation to the veins and the fat paths. So this is how we're going to do the marking. So the lima has been harvested. So this is the PDA graph. Aorta for the top ends. The top end has been done to the aorta. So this is keeping the geometry intact. So the same physiological configuration as we do on the open cabbages. So strategy for the multivessel revascularization. Options include in situ lima to LAD plus minus radial vein grafts. Aortocoronary vein radial grafts if proximal access is feasible. An aortic composite strategy can be applied. Hybrid strategy for the lesions poorly accessible surgically. So common surgical pattern is lima to LAD, vein or radial artery to diagonal or the OM branch. Sequence is important. LAD is often done firstly, lateral ward targets after good exposure is established. Choose a plan that minimizes repeated cardiac displacement. Grafts crossing should be avoided and tension and kinking should be avoided. Haplonize adequately. Intracoronary shunt, it is a very helpful thing. Blow or mister cautiously. Arteriotomy of adequate length is important. Excellent visualization is very important for the good graft quality. Avoid traction injury to the friable targets and maintain graft orientations at all times. For lima to LAD, ensure lies smooth and untwisted. Avoid too distal LAD if conduit length becomes marginal, and check filling and runoff. To check for the graft configuration for also the vein and also the lima, that it is not twisted, what we and everybody do is that mark the graft, the configuration of the graft with a marker. Or sometimes we use the gentian volatiles as well. So that hampers it from twisting and gives the good graft geometry as well. Keep the feet dry, but don't oversection the target. Lower heart rate and control blood pressure help the precision. And if exposure is poor, improve exposure fast. Don't force the stitch line. Exposure of the lateral inferior targets. Use table tilt and deep right lateral traction pericardial stay sutures. That is going to help you a lot. Optimize venous return and filling. Lift heart gradually, but not abruptly. For posterior targets, only in selected anatomy and experienced hands. Hemodynamic tolerance is often limiting factor. If instability occurs, release the traction. Volume load, vasopressors, and inotropic support can be used, and consider temporary cardiopulmonary bypass. That's your friend, not an enemy. Multi-vessel mix often depends on the graft design. The options are T, Y, composite, or sequential grafting can be done because the aim is complete revascularization and the survival benefit by using the IMA. Saphenous vein composite proximal aortic anastomosis can be done. Target location, conduit quality, aortic calcification, the reach and geometry, and the technical priorities are no twist, no tension, no competitive flow, mismatch, and enough graft length after the heart returns to the native position. Always access the graft geometry with the heart in its final resting position, not only during the exposure. As I've already told you, many times it happens that while the grafting is being done, the geometry looks very fine and it's very well, but as soon as you release the heart and it goes into the pericardial well, you see the graft was a little twisted, and that blocks it. So off-pump and on-pump we've already discussed. There's some advantages, but some not advantages, but again, the pump is your friend. So this is one of the patients which we do 4 grafts and PDA is done, and that's been on an arrested heart rather than on a beating heart because the aim is to do the complete revascularization. Intraoperative quality control, confirm the hemostasis along the lima bed, which is very important. Graft lie in orientation, no tension kicking. If you have got the TTF, use that to follow the graft flow. TOE for the wall motion and ventricular function during the procedure. Before closure, lung re-expansion should be noticed under vision. Chest drains are placed thoughtfully. Ensure graft is not distorted by the rib approximation. A beautiful anastomosis can still fail because of a bad geometry. We have seen initially, means what we learned initially, that even in many safe hands, even a single drain is enough. But sometimes, in our experience, that doing 2 drains in a patient, one in the center and one into the left side, so that helps control the bleeding, and the many patients are saved from the cardiac tamponade postoperatively. So there's no harm in putting 2 drains rather than using one single drain. So common pitfalls and how to avoid them: wrong incision, avoid by preoperative planning and target mapping; inadequate lima length, so you may use the skeletonization technique; harvest distally, choose the target wisely; and if at all lima is not means going to get, or it's in tension, you may use a vein extension for the lima as well. Poor target exposure, for that use the pericardial stay sutures, table tilt, batter stabilizer position, hemodynamic collapse during displacement, release the traction early, communicate with the anesthetist, and consider cardiopulmonary bypass. Twisted or kinked graft, check for the orientation, reassess after heart returns. Overambitious multi-vessel plan, choose the stage hybrid revascularization when needed. Conversion is not a failure. Convert early when the targets cannot be safely accessed. Bleeding is not controlled. Hemodynamics remains unstable. Conduit geometry is unsatisfactory. Quality of anastomosis is in doubt. Conversion options are enlarge the thoracotomy, sternotomy, or institute the bypass. Important message is that timely conversion is good judgment, and that is not a defeat. So these are some advanced cases. So this is CABG plus AVR. That gentleman was CABG plus MVR from bilateral thoracotomies. The sternotomy was not done. Take home pearls are: pick good anatomy for early cases, place the incision based on the hard target, harvest more lima length than you think, and sometimes many people, they have got a consensus that if a lima length is around 9 centimeter, that's sufficient to reach any target of the LED. Use pericardial traction sutures, optimize heart rate, preload, and communication skills should be very good with the team. Check the graft geometry after the heart is back. Keep a low threshold for hybrid strategy. Convert early rather than create a bad graft. Final message is that multi-vessel CABG is not a small incision version of the standard cardiopulmonary bypass. It's a different procedure. Outcomes depend on the selection, setup, exposure, graft strategy, and disciplined decision making. The best results come from the reproducible technique, honest case selection, a team that does the same procedure the same way every time. Thank you very much. Any questions?
Any questions?
Cardiology team working with you in those, and do you do lima to LAD on the same day and then do PCI, or do you delay it?
Well, honestly speaking, we haven't done any hybrid procedure so far. We plan our cases well ahead, and we try to do the complete revascularization. If there is any chance of doing a hybrid procedure, we try to offer the patient an open heart surgery. So that's what we're doing, rather than doing only a lima to LED graft.
And on the next day, you do the PCI to vessels. Because after the PCI, you cannot give the protomen.
Yes, exactly.
So you check your lima as well on that during that PCI.
Yes, I think that's the paper from Emory on hybrid paper, the first very detailed paper. So they were doing lima to LED. Next day, checking that lima to LED graft is patent and without any problem, and then do a hybrid procedure. So, Dr. Yasser, I'm glad that you did a fine presentation.
Thank you, sir.
And what I got out of your presentation is the Hippocratic Oath, which says primum non sera. First, do no harm. The second
Yes.
thing is that in any operation or anything in your life, if you do without planning, then your plan is going to fail. So how do you plan? Do you sit with cardiologists, radiologists? How do you plan the angiogram and everything?
Sir,
Or you alone do it?
No, we try to have a small heart team discussion with a group of our small team. The essential members are importantly the cardiologist, definitely to have a look at the angiogram, and before that we do the assessment. We've made a certain criteria that because you cannot offer multi-vessel minimal invasive CABG to everybody. We've made a certain criteria. If a patient comes into that criteria, then we accept it. The major points are that any patient who's got an ejection fraction of less than 35% is not a candidate. Any patient with the diffusely diseased vessels, we try not to perform. Similarly, any patient who has got a weight more than 100 kgs, we try to avoid him being an obese, especially if he's a short stature. Anybody who has got a height more than 6 or something like that and fit enough, so we do offer him. So this is a general criteria. Any patient who comes into the criteria, then before going to the theater, we sit with our cardiologist and then plan the number of grafts, number one. Number two, then a brief team meeting is done before the procedure, especially with the perfusionist. Tells him that if I need to go on a bypass, so this is our plan. These cannulas, these sizes, you should be having that in your mind. Then I tell my scrub nurse that a certain amount of things they are necessary, and then we perform the surgery. So this is how we do it. This is only with the discussion of the cardiologist, because they're very good at looking at the angiogram. So that just the coronary angiogram. We don't routinely do the CT because, again, that increases the cost of the procedure also. I also still remember our very first case, which we did minimal invasive MIDCAB. It was a single graft, lima to LAD, and the LAD was intramyocardial. And rather than performing it minimal invasive, I just converted it to the full sternotomy and did that. So this is what happens, sometimes happens.
Yes, sir. Just a few comments that I want to make. I think I just saw some of the incisions, and some of them are very close to the nipple.
Yes.
I think you have to be very careful, because once it heals, the nipple can get very distorted and extremely sensitive, and when it touches the shirt, then it is very uncomfortable for the patient. So I think you really need to leave some distance between the nipple and the incision. That is one. Number two is, I think one of the single most important factor for pain post-thoracotomies is the chest tube. Chest tubes are very painful, very uncomfortable. So I quite like your first idea that just put one chest tube. In peds, many a time we don't even put chest tubes in. And I think if you can do away, because if you are bleeding, one tube or two tubes, they are not going to save you from tamponades. So I think by and large, avoid putting two chest tubes, because the distance between the two tubes will be very close for the type of incisions that you're using. So I think that is the second suggestion. In females, obviously, do you always go sub-memory, or do you just go above the...
No. Sir, in females, we always go sub-memory.
Yeah.
We never go above. We always sub-memory incision, and we have seen doing females is rather easier than doing the male.
Yeah, because you lift up the back.
Exactly.
Yeah.
And secondly, it was in the very beginning of the program, we used to go close to the nipple. Then we changed the complete strategy, because in those times, the single graft lima to LAD, we thought that it's because as close as to the sternum we are, so the harvesting of the lima becomes easier. But with the passage of time, we learned that it should be not close to the nipple. And secondly, about the chest tubes, sometimes when we are using the two chest tubes, one is into the chest, the other is into the mediastinum subxiphoid we take that. And we always use the bupivacaine block, and we block the 3 spaces. One, the same intercostal, 1 space above and 1 space below. And so the pain gets controlled well with the block so far, which we've seen.
I think the last thing I would like to say is that never fight the size of the incision. Be generous with it, because at the end of the day, you want a very good anastomosis. So 2 centimeters, and you start to, becoming shy of getting it to the 3 centimeter. I mean, I think that's not fair to the patient. The thoracotomies heal very well. So if you have a little larger incision, doesn't matter at all.
Exactly.
Remember, a person who had never had a cut before, for him, 2 centimeter or a full medius sternotomy pain is going to be the same.
Exactly.
Because he cannot relate it to anything. If you go for Hajj first time, whether you do a 40 days Hajj or you do a 5 days Hajj, it's going to be equally, stressful for you. So at the end of the day, I think it's the safety which matters. I certainly agree that the surgeries done through the thorax heal much better. Obviously the level of complications will be much, much less. And if you can avoid sternotomies, yes, I think I'm all for it. I think splendid job you're doing.
Thank you,
really.
sir.
Well done.
Thank you. Thank you, Sir. Thank you.
Sorry?
It's regarding Lima harvest. So usually you approach through 4th intercostal space, and when you harvest the Lima, length may be inadequate. Sometimes, because I've seen harvesting distal is much more a problem. So I think, how do you address that?
Well, the length of the Lima is never a problem. Once you are doing it routinely, so you always take a good length of the Lima. It all depends upon whether you're going through the 4th or the 3rd space. Because when I was presenting my data last year in the European Society of Cardiovascular Surgeons, so there was a gentleman from probably Turkey, and they were doing, because they wanted to do the proximals always on the aorta, and they were finding it difficult to do it from the 4th or 5th intercostal space. So what they used to do is that they were going through the 3rd space. When you're using the 3rd space, the length of the Lima is always going to be shortened. But when you're going to go from the 4th or the 5th intercostal space, the length has never been a problem. Once you've got the right instruments available, the good length of the instruments available, the length of the Lima is never a problem. And secondly, it means we try just to go up till the 1st intercostal, that branch of the IMA. We always try to clip it, and even if you're not going to take it down, just clip it, that works. And according to the new data, it's a very good paper from our own, very good friend of ours from the Harefield Hospital, Shahzad Raja. It says that even if the length of the Lima is shortened, the concept of that stealing from the 1st intercostal, that's a bit old concept now. So there's no data supporting that as well. But as long as you're using the right instruments, the length of the Lima is not a problem.
But if you use a rail track detector and use a sky hook, how can you extend it distally up to the 5th intercostal space if you open in the 4th intercostal space?
Well, you don't need to.
Because it will always be shorter, I believe. It will. We have harvested up to the, you say, proximally. But sometimes, when we open up, we harvest it distally up to the 5th or 6th intercostal space. But here we are into the 4th. I hope I've discussed with the professor, I've always find it difficult when you can't do it on distally. what is your take on that? You cannot.
I think probably Dr. Parvez Chaudhary is going to address this issue and the rest of the questions in the...
And final question is that
Yes.
how many times you employ a scope, and what scope and what intercostal space you use?
For the harvesting of the IMA,
Yes, yes.
I do it with a naked eye.
You never employed a scope?
No,
And
I
you
do it
don't
with a
find
naked eye,
any
and
need
I
to do
feel
it?
very comfortable doing it with a naked eye rather than using a scope. That takes a lot of time also, but with a naked eye, it's just 20-25 minutes max.
Thank you so much, Dr. Yasir Saab. A very nice presentation, and I know your experience. Whereas Chaudhary Saab is here. Yeah, lima harvesting probably is the trickiest, but the easiest one when you get it properly with the proper fourth intercostal space, and you go up to the first intercostal, and then you change the settings, and you come. Sometimes you need a little bit of the Zerni retractor by the assistant's hand to go down, and then you can reach even the bifurcation down to harvest it completely. My question is that, and it's a bit of comment, like we surgeons always play on indication class 1, level A. And that is our strength, yes. But to start the program, you can make exclusions, and you must, because safety comes first. And when I started probably in 2017 with upper minister anatomy AVRs. And later on, a man from Mali came who was actually crippled, having an artificial limb. He ended up in Tabligh and ended up in my unit. I wish I could do MIDCAB for him at that time, but I offered him open with the assistance
Thank you,
of
sir.
the limbs.
Due to time constraints, we will proceed to the next session.
Sorry, my comment is that to please, for experts, those centers which are developing like his, do not put this bar that this patient is not. Look at your circumstances. If you can do obese lady, if you can do a crippled person with the MIDCAB, probably offer them, because TAVI was explored the same way and PCI was explored the same way. But be safe and be confident in your hands. Thank you.
Thank you, sir. Before we move on to the next session, I have an announcement. We have refreshments arranged outside the auditorium and may be availed at your convenience. The next session discusses approaches to minimally invasive mitral valve replacement. I would now like to invite Brigadier Mohammad Amir Khan, who is the professor and head of Department of Cardiac Surgery at AFIC Rawalpindi. He has performed over 3,000 cardiac surgeries and has keen interest in minimally invasive and keyhole cardiac surgery. Please join him as he delivers his presentation. Sir.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Tariq, for inviting us to this wonderful, minimally invasive, first ever conference in Pakistan. And today I'll be talking about minimally invasive mitral valve surgery. Mitral valve surgery using traditional median full sternotomy is the conventional approach for treating mitral valve disease. Treating traditional median full sternotomy provides good surgical vision and outcomes, but requires complete sternal division, increasing the chances of bleeding, postoperative pain, and loss of sternal integrity. In the last few decades, minimally invasive mitral valve surgery has gained consensus among surgeons because it improves patient satisfaction while maintaining the same quality and safety of traditional mitral valve surgery. In 2008, an American Heart Association scientific statement defined minimally invasive cardiac surgery as cardiac surgery performed through a small chest wall incision that does not include the conventional full sternotomy. As already discussed, this minimally invasive access reduces the surgical trauma and postoperative pain, decreases the blood loss and transfusion requirements, lower wound infection risk, shorter recovery time and hospital stay, and better cosmetic result and higher patient satisfaction. The criticism for against minimally invasive mitral valve surgery or cardiac surgery is that it is technically more complex. It's because of the limited exposure and the limited visualization and the increased distance of the mitral valve from the chest wall and the utilization of long shaft instruments. It does requires a distinct learning curve, and there are some earlier side effects of endoaortic balloon occlusion, which resulted in neurological events and aortic dissection. And there are also some groin complications which are mentioned. And there are levels of ascent in minimally invasive cardiac surgery. Actually, at level 1, you can perform surgery through under direct vision through limited 10 to 12 centimeter incisions. At level 2, you can incorporate video assistance and perform surgery through mini incisions. And at level 3, totally video-assisted visualization is used with or without robot assistance through microincisions, and at level 4, total robotic computer telemanipulation surgeries are performed through port mini incisions. So this is the minimally invasive approach. It can be done through the lower sternotomy, upper hemisternotomy, or right mini thoracotomy under direct vision, or with videoscopic visualization through port mini thoracotomy without robot or with robot assistance. So minimally invasive approaches to mitral valve surgery is the commonest is the right mini thoracotomy. It can be performed, it is performed majority of the cases under direct vision. It can be performed with video assistance or fully endoscopic surgery or robotic mitral surgery. And nowadays a new procedure has been evolved. It's transapical beating heart off-pump new caudal mitral valve repair. It is just a newly developed device, NewCord DS1000 system, which facilitates transapical implantation of new chordae to correct mitral regurgitation on beating heart without cardiopulmonary bypass under 2-dimensional or 3-dimensional echocardic guidance. The NewCord device enables implantation of new chordae using PTFE sutures to the prolapsing mitral leaflet. After grasping the mitral leaflet tissue with 2 grippers, embedded color-sensible fiber optics allow for verification of sufficient tissue grasping, and piercing and fixation with subsequent retraction of the new chordae are realized using a special needle. After a girth of hitch knot is tied and slid to the leaflet, the 2 free ends of the suture are then fixed to the left ventricle apex at a defined length for correction of leaflet prolapse. So this is the new technique, and a study has been published, and they have published a 1-year results with good outcomes. And this is the that device, and under 3D echo-CAR-T guidance, this is that NeoCordy. Now, minimally invasive mitral valve surgery to right mini thoracotomy is the gold standard, and we are performing that regularly. On करना play कीजिएगा उसमें. A double lumen endotracheal tube is placed. An SVC cannula is placed through the right intrajugular vein by the cardiac anesthetist, along with the central venous line. Our transesophageal echo probe is in situ to guide the peripheral femoral cannulation. This is the draping. 3 centimeter inguinal incision is made. Femoral vessels are pursings are passed. And using Sandlinger technique, first the femoral vein is punctured, and over the guide wire, the femoral venous cannula is placed. under TE guidance from the IVC into the RA and into the SVC. Similarly, femoral arterial cannulation is done by Sandlinger technique, and this guide wire is seen in the descending aorta under TE guidance, and then femoral arterial cannula is placed and connected to the cardiopulmonary bypass circuit to establish the cardiopulmonary bypass. A 6 to 8 centimeter incision is made in the fourth intercostal space. A soft tissue protector is used for a good exposure. And after, with the rib spreading, the pericardial incision is made in the pericardium as anterior as possible so that the posterior flaps could be used for pericardial sutures. The interatrial groove between the right atrium and the left atrium is dissected out. And pursing sutures are placed, and for the antegrade cardioplegia cannula, it's a long antegrade cardioplegia cannula which is used, which is then connected to the cardioplegia line after dearing. A Signet aortic cross clamp is used to cross clamp the aorta. The left atriotomy is done, and so through a separate stab incision, a left atrial retractor is placed, which is connected to his and the flap is the left atrial wall is retracted to expose the mitral valve. And the incision is made in the mitral valve between the mitral annulus and the anterior leaflet, and Plagitate 20 ethibond sutures are taken from the annulus. In this case, we excise the anterior mitral leaflet, and the whole complete suture line is there now. All the stitches are in place. Then these sutures are passed through the mitral valve, and the mitral valve is positioned in the mitral annulus, and the knots are then tied using a knot pusher. As you see that you need your assistant to assist you in this knot tying, so the coordination between the principal surgeon and the surgical assistant is very important, so that the knots are not loose, because that can lead to paravalvular leak. For mitral valve repair, even if the knots are loose, that will not cause paravalvular leak. So, but in valve, it is very important. So once after checking the valve and the mitral valve, left atrium is closed, the pacing wires are passed before declamping the aorta. And these are then taken out along with the pericardial pleural drains. And the aorta is declamped, and after dearing, aortic dearing cannula is removed, and patient is weaned off cardiopulmonary bypass. Venous cannula is taken out, and after transfusing the blood, the femoral arterial cannula is also taken out. Hemostasis is secured in the groin, and that wound is staged. And lungs are inflated, and hemostasis is secured in the chest. And soft tissue retractor is taken out, and the chest wall is closed in layers. So this is the scars after the minimally invasive right thoracotomy incision. And now, just for the initial beginners, we just want to discuss the methodology which we can evolve in the intraoperative strategy. If two surgical teams are trained enough, so they can start simultaneously to save time. The first team can do the peripheral femoral vessel cannulation, and the second team can start off with the right main thoracotomy and try to complete as much chest wall dissection as possible before heparinization. For femoral vascular access, percutaneous femoral arterial and venous access can be done by Seldinger technique using dilators. But in the majority of the time, we use an open method in which a 3 centimeter incision below the inguinal crease is given through the cribriform fascia, just to keep the dissection limited to the anterior aspect of the femoral vessel only. Do not dissect on the lateral or medial aspect. That will either damage the femoral nerve or laterally or on the medial side on the lymphatics, and can lead to formation of seroma formation postoperatively. So it is very important that you should just limit the dissection to the anterior aspect of the femoral vessels. And use of the vacuum-assisted venous drainage does help in the venous drainage. This is the T view, which we will, bicable view, which you would like to have for your peripheral vessel cannulation. This is the IVC, this is SVC, RA, and then the LA. And you should always make sure that the guide wire is passing from the IVC into the SVC. And once the cannula is placed, you should always check this, that it has passed from the IVC into the LV. Why is it important? Because sometimes the guide wire passes not into the SVC, but either into the RA appendage or through the PFO or ASD into the LA. And if you push the cannula along with this stiff stellate, then you are liable to puncture the right atrial appendage or the LA appendage. So you can damage that. So you should always ensure that the placement of the cannula is correct. And similarly, for femoral artery puncture, you should always make sure that the guide wire is visible in the descending thoracic aorta, so that there is no dissection or aortic complication. If the patient is very obese and the femoral artery size is very small, then you should always try to cannulate the common femoral artery above the profunda femoris artery. Should not cannulate the superficial femoral artery. So always expose the common femoral artery first. If even that is of small caliber, then you can go higher above the inguinal ligament and try to cannulate the external iliac artery. Or in some cases, you can cannulate the axillary or the aorta directly through the main thoracotomy incision. After femoral arterial cannula is removed, you should ensure that there is no arterial bleeding. And if you take some stitches and that causes narrowing of the femoral artery, try to avoid that, and you can use a venous patch to repair that portion. For a skin incision, for a right main thoracotomy, valve should be in the 4th intercostal space. Try not to go above this, the angle of the rib. Because if you do that, try to keep laterally and parallel to the rib from the 4th intercostal, between the 4th rib and the 5th rib, and stay on the superior border of the 5th rib to avoid intercostal bundle in the lower border, and keep parallel to the rib. Because if you go above this and the angle is exposed, the retractor usually slips many a times during your procedure. So that's you want to avoid. So the incision should be on the lateral aspect. For pleural incision, you should always deflate the right lung before pleural incision to avoid lung injury. And before pericardial incision, majority of the patients have a bulky pericardial fat over the pericardium. So if you dissect that out first, that helps your exposure later on. So dissect that out first and then give an anterior incision in the pericardium, so that posterior pericardial fat could be used for traction, and that will bring the LA and the aorta nearer to the incision. Similarly, if right hemidiaphragm bulge is in obese patients is sometimes very high. So what you can do is you can take a Plagitate 20 ethibond suture through the central tendon of the diaphragm and then pull it downwards towards the foot through the fifth or sixth intercostal space. That takes out the dome of diaphragm from away from your exposure. And similarly, antegrade cardiopulmonary cannula, we always try to put 2 purse strings, the second one with Plagitate, so that unfortunately, if somehow mistakenly, if the thread is broken during tying, so you always have a second purse string to tie that cannulation site. And for cannulation strategy for mitral valve through the right atrial approach or for tricuspid valve repair, you need to put the SVC cannula slightly higher above the SVC RA junction and the IVC cannula in the IVC so that you can snug the IVC and SVC. We usually use a double silk suture and for a loose tie and to snug the femoral artery. For suturing, secure knot in mitral valve replacement is very important because if that knot is loose, it can lead to paravalvular leak. For mitral valve repair, when you place an annuloplasty ring, even if that suture is not tied very securely, although that should also be tied securely, but that will not cause that much harm as in case of mitral valve replacement. So as we discussed earlier, that while using a knot pusher, the coordination between the assistant and the surgeon is very important. And nowadays, a core knot is used in developed countries, although the cost is the barrier in our population in our country, but it does secure a very good knot. And for cross-clamping aorta, we use Signet cross-clamp through the same incision, although Chitwood clamp can be used through this second or third intercostal stab incision. But ensure that the entire aorta is clamped, cross-clamped when you place that cross-clamp, and avoid damage to the pulmonary artery and the left atrial appendage while clamping the aorta. End-aortic balloon occlusion is used in the developed countries, but we don't have any experience of that. Pacing wires should be placed before declamping the aorta, and these can be tag them with the peripleural drain and take out from that stab incision. And while closing that, the chest wall and intercostal nerve block, as said by Dr. Khaqani, 3 intercostal spaces, one above and one below, and the same incision intercostal space is injected with bupivacaine for intercostal nerve block. So the mitral valve surgery continues to evolve with technical advances facilitating more minimally invasive approaches. There are now several minimally invasive strategies to repair the mitral valve. Outcomes of studies have demonstrated safety while promoting quicker recovery and improved postoperative functional status. Continued innovation with a focus on minimally invasive mitral valve interventions together with advances in valve repair and prosthetic design will further enhance the care of patients with mitral valve disease. Thank you.
Any questions?
Yeah, you are audible. Yeah, clearly audible.
Thank you, sir. I remember in 2014-15 when you would come to Rahman Saab, he would. My question is that there are 2 actually. If there is AF and you have to do the LA application, what is your experience with that? And second, like I had a patient in which there was concomitant RCA severe disease. So I had to do a venous graft to that through the same. It went very well, but I added core knots.
Okay.
Core knot costs around 2,25,000.
Core knots for mitral valve or for the distal anastomosis?
No. Core knots for the mitral
Mitral valve, okay.
Distal and proximal anastomosis I could do with the
Hand
naked
swing.
eye, yes, with
Okay.
loops. So to reduce the time, I used core knots on the mitral valve, and it went very well. So how is your experience with the core knot? Because I'm comfortable with that. A better patient, some patients are comfortable with the cost. 2,25,000 it adds to a single patients, and there are some refills which actually then cut the cost down by 75 to 50,000 if you are using the refills. But there are some concerns regarding core knots and the manual knots. So how you find it as a comparison, if you are having any experience in that?
To be very honest, we have just used core knots in 10 or 12 patients only. So we can't relate that to big experience, and we can. But in experience hand, it does reduces your surgical time, and the strength of that knot is, as I have seen on those 10-12 patients, is the same as you do it with knot pusher and this. And as far as the question of the LA appendage occlusion, what we do is we don't do it, the LA occlusion with the, although there are devices nowadays available, you can just hold the LA appendage below the aorta through the transverse sinus, and you can clamp it. That device cost you around 5 to 6 lakh rupees. But what we do is we do a double layer suture through the same LA incision, and we close the LA appendage from there. No, only in AF patients.
Dr. Farid. I just want to add some few additions. First of all, for the core knots, especially when we are doing minimally invasive double valve procedures, core knot is a blessing because it really cuts your operating time, and you are getting tired as well tying that many knots with the knot pusher. So especially in double valve minimally invasive procedures, core knot will really makes a difference. Second, regarding the LA closure, we do the LA closure from inside. I must say that the exposure and the vision of the mitral valve through minimally invasive approach is much better than the sternotomy approach. It's direct exposure. You are looking right in front, and we use the LA lift. So mitral valve is right in front of you, and it's same as with the left atrial appendage, and you can close it from inside. So in our institute, what we have learned that our anesthetists are not trained with the jugular venous cannulation, and we tried in the early days with double venous cannulation through femoral, and we got one incidence of rupturing the LA because of malalignment of that venous cannula. So now we developed this habit that we slide in and keep our venous cannula below the IVC. So we open, and then we feel the IVC cannula, and under our own vision or feeling, we guide it into the SVC. We don't rely on the cardiologist at all anymore now. Second thing, sir, my request to you, if you start putting the diaphragmatic hitch stitch regularly and start using the Chitwood clamp, this will take out the space in your incision, and you will be very easily able to constrain your incision till 5 centimeters. So Chitwood will take separate incision, and you hitch the diaphragm. Even with 5 centimeters, you will be able to have a very excellent exposure. Thank you.
Thank you.
Dr. Mangi.
I would rather use right angle SVC cannula direct into the SVC, rather putting this femoral cannula up to the SVC, because it will give you a more room for operating in the mitral valve. Because if you want to open through the transseptal approach, or if you are going through the LA approach, so you will have both options open. Whenever you are going from the femoral brain up to the SVC, so you are limited to the left atrial approach only.
No, if you go, no.
What we do is, if we have to repair the tricuspid valve, we
pull the IVC cannula back into the IVC and snug it above that.
just put LV vent into the SVC. So it's a long LV vent. So just like we are putting a cardioplegia cannula, same way SVC first ring, put a SVC first ring, LV vent, attach the second line to the LV vent, and make a bypass circuit for.
So the same way, if you want to make easy, you put in a femoral, you wire it, and put in the same SVC cannula that we put in open hearts, right? Like the open chest one, and just wire it. Even if you have to go through the LA or RA, or if you have to do a tricuspid concomitant, it won't make any difference. Just snug it down, and you have the same return.
Yeah. And on the basis of use of coronary in minimal invasive mitral valve, we are using it commonly, and I don't think it is that much costly, because they have both options. If you are buying a coronary with the gun, or if you are buying only the coronaries, because gun can be restarted for next 5 cases. So we are doing it in a regular form, that we are using 2 guns and re-sterilizing them, and we are just using the coronaries in every case. It costs less than 200,000 rupees.
Just for the knots.
Yes.
Just for the knots, that adds up to the, if you are doing a DVR, just it goes to around 2 million then.
Why 2 million? Because it is 200,000, like about, if you are using for 2 valves, so you will have around, for 2 valves, it will be 400,000.
400,000. For whole operation, the operation cost.
Normal cabbage cost in the public sectors.
Yeah, it's compared to yeah.
Just 2-3 comments before we close. Beautiful and lovely presentation, Dr. Amir. One thing is that if femoral artery is small, I usually attach a PTFE 8 mm through which you can then perfuse the aorta. The second thing is that, yes, there's a debate about going with one cannula versus 2 separate cannulae. The reason being that some people find it too stiff to pull upwards.
Yeah.
And the third thing is that be cautious, particularly in the West, with the submammary incision in female who have had previous surgery for breast augmentation, then implant have been ruptured. So take a cautious history from your patients. There are case reports of that.
Because I've seen quite a few disasters. Unless you patch the femoral artery properly, you can have femoral artery occluding, and you'll have a distal limb ischemia. So I think it's always a good idea to put 6 millimeter PTFE graft in.
If you feel like femoral arteries are smaller, then during the operation you can use a reperfusion cannula into the femoral artery through a 6-inch femoral sheath. So it will supply at the same time your distal limb also. So you will be away from these complications. Venous drainage will be not be the issue, because veins are always bigger. And we use a bigger venous cannula, like 25 French. 6 French femoral artery. I am using in the femoral artery. Like your femoral cannula going upward towards the iliac, and femoral sheath will go towards the femoral.
Yes.
Can I make a comment? Hello. Can I make a comment, please? So this is an overarching comment. We're in 2026, and I think a lot has been talked about the learning curve. I think ethically it's not really good for us to be learning on patients, and I think technology is going to come to our rescue over there. 3D printing was talked about, AI is going to be talked about, and then digital twins are going to be talked about. So you can actually do your operation the day before, the night before, on exactly the patient that you're going to operate the next day. And that should help you with a good outcome. So I think watch the space. We have to embrace technology. It is there, it's coming, and we should embrace it. I think that's where we lagged behind in the past couple of decades. We need to catch up on that for our patients' sake. Thank you.
Another thing I would certainly like your opinion is whether to develop the Sondergaard groove or not. Some people prefer to go directly in the LA because they find that after developing the Sondergaard groove, it becomes very thin and stitching may be difficult. Or what is your practice and what do you suggest?
To the mitral.
Memory, yes, you're a bit away in the auxiliary, but if you're doing in the second or third phase, you can just have a bigger not the same way in the open. But sir, in redo, the person has a previous redo, this is not going this time, which is a better approach. So it's easy to drag down the right field from the vein and start rather than developing something. That might be challenging.
Yeah, these approaches are sort of divided when I looked at literature on this, that some people prefer to develop the Sondergaard groove and then go in, whereas other debate that the tissues then become too friable to close, so they go approach it directly.
Thank you.
Thank you, sir. Our next presentation will cover right anterior mini-thoracotomy AVR, ascending and hemi-arch repair. For this, I invite Dr. Zia Khan, a highly skilled cardiac surgeon with international expertise in advanced cardiac care. He has previously served as a clinical associate in minimally invasive cardiac surgery and structural heart interventions at Houston Methodist DePaul Heart and Vascular Center, USA. He is currently serving as a consultant cardiac surgeon at National Heart Center, Royal Hospital, Oman. He will be joining us virtually via Zoom. Dr. Zia Khan.
Ladies and gentlemen, this is such a great honor to be here amongst friends and colleagues. I just wanted to confirm if you can hear me and see my slides. If somebody could just say yes, or Waqar can maybe text me, and then that way we can keep going. Okay, I think I heard somebody say we can.
Yeah, we can hear you clearly.
All right, so great, thank you. So, Assalamu alaikum, Juma Mubarak to my friends, my colleagues, members of the audience, and the organizers. This is actually a great honor for me. I have to be honest, I was very ignorant about the landscape of mixed surgery in Pakistan. It is my small part of this program. And I hope through this platform we can create pathways for collaboration and mentorship for trainees and junior consultants. I obviously have a lot to learn from your experience, and I hope I can help in mentoring some of you to provide the best care possible for our patients. So before you start wondering who this guy is and why is he here, so let me tell you a little bit about myself. I'm ethnically Pushtun. I am from Swat Valley. I'm an Omani citizen. I went to medical school in Bahrain. followed by 4 years of general surgery in Oman. And that's when I realized that I prefer the smell of blood over feces. So I decided to do 6 years of cardiac surgery residency at McGill in Montreal in Canada. And that's when I realized that I needed a little bit more pain in my life. So I decided to do some more training in minimally invasive cardiac surgery and structural heart interventions at Houston Methodist. And for the past couple of weeks, I've been honored to come back to Oman. I'm serving as a cardiac surgeon at the National Heart Center in Oman. I've been incredibly fortunate to run the Re-Evolution Summit. It was this year we had our 14th iteration. It actually concluded a couple of weeks ago in March, and for the last 2 years I've been running it. It is one of the best minimally invasive training courses in the world. We have expertise from all over the world coming in to teach these intricate procedures to junior consultants, to consultants of all training, to junior trainees, etc. And I hope next year you could join us at Houston as well. All the talks from the recent Re-Evolution Summit that happened a couple of weeks ago are on the DeBakey YouTube channel. It's completely free. Anyone can come and log into the DeBakey Houston Methodist YouTube website, and it's a great platform to learn cutting-edge procedures from some of the best cardiac and vascular surgeons in the world. I really encourage all of you to check it out. So cardiac surgery is not a solo sport. We all know that. You learn it by standing next to someone who's done it 1,000 times and paying attention to every small detail. Mentorship in cardiac surgery is not optional. It is the difference between struggling for years and progressing within months. And I can clearly say that everything that I do well in the operating room today is a reflection of the people I trained with. You will inherit their habits, you'll inherit their judgment and their discipline. So with that, I'd like to segue into talking to you about some of the mentors that I had. This is Dr. Hilal Sabti. He is a cardiac surgeon by training. He is also the Minister of Health of Oman. And he was the one who actually pushed me into moving towards cardiac surgery. I remember I was a 4th-year general surgery resident, and I had just finished my transplant rotation, so I could sew with a Castro, but not as well. So I went into his OR just because I had never seen a cardiac surgery case before, and he really took me under his wing, and he decided to call these two gentlemen in Montreal, Benoit Deveren and Kevin Lachapelle. Now, Benoit Deveren and Kevin Lachapelle are both French Canadians. They're cardiac surgeons who practice at McGill University in Montreal. And something about French people, their humor can be quite raw. So I did my first ever cardiac surgery case with Kevin Lachapelle. It was a straightforward cab. I was taking my first ever mammary artery. And obviously I was nervous. It's the most important conduit. We've talked about it. Everyone has opinions on it. So letting a 2nd-year cardiac surgery resident take a mammary down for him was obviously quite nerve-wracking, and for me as well. So he comes in, I'm taking the mammary down, and he's like, don't worry, the patient cannot see your hands trembling. So his sense of humor was quite raw. Benoit Deveren is one of the most prolific mitral surgeons in the world, and I'm really, really happy to have trained with him. My last case on my last day in cardiac surgery residency, he gave me a Bentol to do. Obviously, I wanted the case to go really well, so I took my time with it. And then 4 hours later, he comes into the OR, screams at me, tells me, you need to finish this case before the patient dies of old age. So these are some of the kind of people that I trained with, very, very tough people. And I think in cardiac surgery, that's what you can expect. So that is when I landed in Houston. After finishing my general cardiac surgery training, I came to Houston Methodist. I was full of ambition, I was full of energy, and I was full of optimism. I had big dreams of small incisions because at some point I've looked at a sternotomy, and we've all looked at a sternotomy and thought that there has to be a better way, and that is why we're here in Peshawar today. Now the question is, can we actually do it safely and reproducibly and without losing our sanity in the process? So this is when I met Dr. Mahesh Ramchandani. Unfortunately for him, he is my mentor. Unfortunately for him, he is also my boss. He's been a phenomenal mentor and the backbone of the mixed cardiac surgery program at Houston Methodist. And when I first started, he looked quite well-rested. He looked quite young. But slowly over the past couple of years, I've noticed that he's more wrinkly, he's lost more hair. And towards the end of my training, which was like last month, this is how he looked. So this is what mentorship in cardiac surgery actually does to the mentor. Again, I have no disclosures, so let's get to the talk. I've noticed that on the agenda, there was no talk on minimally invasive AVR. So I took a liberty to talk about minimally invasive AVR through a small incision. And then once we know how to do that, we can go into more advanced stuff. I have no disclosures. I just have strong opinions and a little bias towards smaller incisions. So let's be honest, no patient wakes up in the morning and says, thank God I'm getting a sternotomy today. They want faster recovery, they want less pain, and they want smaller scars. At the same time, we as surgeons, we want our operations to be safe and reproducible. And the hospital administrators want shorter length of stay and better outcomes. So the question is not, can we do this minimally invasively? The question should be, why aren't we doing it minimally invasively already? So let's dive right into it. Before we jump in with our instruments, we have to decide if the patient is anatomically a candidate for a mixed approach or not. So in a mixed AVR, there are a few things that you have to keep in mind. You have to make sure that the aorta is on the right of the midline. You can operate on patients whose aortas are on the left of the midline, but I assure you it is going to be very, very tricky and you'll hate your life. The second thing that you need to know on the CT scan is where the root is in comparison to your incision. The incision should the root should be essentially 1 intercostal space or 2 intercostal spaces below your main incision, because if it's too low, like in elongated aortas, which we've all seen, it can become quite tricky. And if it is an elongated aorta, then I prefer to go in the 3rd intercostal space. And in some cases, I've also transected the rib and put a plate or a wire at the end of the case. So very important to have the aorta on the right of the midline and making sure that the root is not too far away. So pretty usual setup. I don't do anything fancy. I just position the patient supine. I mark the midline of the chest, have the whole body prepped and draped. So let's get on with it. So pretty straightforward. We go in the 2nd intercostal space. We don't usually transect the mammary artery, but obviously you can if you want to. We put a CO2 line, a soft tissue retractor, and a rib spreader. Femoral cannulation is your friend unless you backwall the femoral artery. Then in that case, you need new friends. But whether you do it open or percutaneous is entirely up to you. The most important thing over here is that you need to make sure that you do it under TEE guidance. I've heard some people saying that they do it, by finger manual manipulation, etc. I haven't. I'm not very good at it. Maybe because I'm very young in my practice. But I prefer to, I'm completely reliant on the echocardiographer. So at this stage, we give heparin and we go on pump. I've always noticed that it's so much easier to open the pericardium and remove the pericardial fat when you're on pump because everything is completely flaccid. So the key over here is to open the pericardium on the top of the aorta whenever you're doing an AVR. And now the next thing is that you have to put 3 to 4 pericardial stitches on the left side of the pericardium and stick it to the skin. What that does is that brings the aorta to the level of the skin. And that makes the operation a little bit easier. I used to put it, I never really thought about it in the beginning. I would always put the right-sided pericardial stays. But by putting the left-sided pericardial stays, you can really push the aorta all the way up to the level of the skin. We use a Carter-Thompson device. You can use any suture passer, and this is basically the exposure you get. I always dissect behind the aorta to find place for my clamping. I've used a Signet clamp, but lately I've been using the chitwood. I just feel like the chitwood is a little bit easier because it's out of your way. So lately I've been using the chitwood cannula for clamping the aorta. Some people don't create that space under the aorta. I just always feel comfortable to have like some empty space in order to make sure that my clamp is all the way across. An LV vent was inserted, obviously. So this is a case of, let me see if I can get that done. Yeah. So this is a case of a patient with the AI. We come off pump completely before cross clamping. You can see the heart is beating. We open the aorta very carefully. We try not to be too artistic with our aortotomies because obviously If you open it in a very weird way, it's hard to close it. We go towards the non-left commissure always. Here, you can clearly see that I'm in the left coronary ostia, and I'm giving cardioplegia. We used El Nido. I've heard somebody say about custodial. I have no experience in it, but I've only heard good things about it, and I hope I can get my hands on custodial. Now, I'm just going to pause it right here because it is very important to have the annulus facing you. Because if you're operating through a barrel, you need to make sure that everything is in front of you. So I put 7 retraction stitches. So the first one is on top of the aorta where I transected it. I bring it out. The second one is on the left side of the aorta. Again, I bring it out. I've stopped using pledgets lately because I'll be honest with you, there was one time that I lost a pledget in the LV, and we had to convert to a sternotomy in order to make sure that we got the pledget out, and luckily we got the pledget out. So I stopped using pledgets on the aorta when I'm doing my retraction stitches. Just keep in mind, you know, some of the screw-ups that I've had, I don't want anybody in the audience to have those same screw-ups. So second pericardial stay on the left side, then one on the right side, bring it out, and as you can see, with each stitch, the aorta comes closer and closer to the surgeon. Now, this is important. This is where the divot is, where the incision was made. So this one needs to come out as well. I actually realized this through trial and error. Now, once this is done, the aorta is towards you, but the annulus is still pretty far, and it's not looking at you directly. So what you do at this stage is you put commissural stitches. You can use a 4-0 or a 5-0 or whatever you want to use, but you put 3 stitches, one on each commissure, on top of each commissure, and then what that does is then you're staring directly at the valve. As you can see, the valve is already getting in the view of me, and this makes the operation a lot easier. So this is the kind of exposure you expect to get at the end of your aortotomy. At this stage, if your exposure is not good, you have to adjust your table, adjust the retractor, or just adjust your expectations and just keep going. Pretty straightforward over here. You could, sorry about that. Yeah, so we used a sutured valve over here. I also do sutureless valves, particularly the Percival valves. Dr. Ramshdani has a lot of experience with it, and I'm fortunate to have learned it with you. So I use a Cornot. There's been a lot of discussion about Cornot. In my operating room, we always say Cornot, why not? I think it really sits the valve down really well. But if you don't have the Cornot available, the valve is actually quite close, and you can use your own fingers to tie the valve down, or use a knot for sure, whatever your preference is. This is a video of a Percival valve. Again, I'm a big fan of a Percival valve. It decreases the cross-clamp times by 48%, especially very helpful in double valve, triple valve, or combined procedures, or if you're doing it in the second case of the day, this can really be helpful. So you put 3 nadir sutures, bring the valve down, balloon it, and just close the aortotomy, you're done. Now, at this stage, it is very important. I'm sure everyone's feeling great about doing the AVR, but closing the aortotomy is equally as important. You have to make sure that you close the aortotomy with a lot of love, with a lot of care, because bleeding from the aorta when the heart's pumping can be quite intimidating. It can be done. Now, again, very important to put the pacer wire before you take the cross clamp out, because once the heart starts beating and is full, it is very hard to put pacer wires in, and I've learned that from my own experience. So I don't want you guys to fall for that. Always put the pacer wires in. It takes like literally 30 seconds. Put the pacer wire in and exteriorize it. Here, the cross clamp is removed. I core knot everything. I don't think I've tied a knot in a couple of years now. Here we are putting marking with Exparol. It's a liposomal solution, and we're injecting it into the intercostal spaces. Lately, we've also started using cryo, and it definitely helps with nerve pain for up to 3 to 6 months. So that definitely helps. So obviously, we have to make sure that our data is good, because what's the point of telling you how good I am if I don't show you my actual data. So the first two cases were actually quite humbling, but the outcomes improved pretty fast because I had great mentors and they walked me step by step along the way. So the learning curve can be real, but once you're over it, it is actually a very beautiful place. So we looked at our outcomes of mixed AVRs performed by advanced fellows such as myself at Houston Methodist. These cases half of their fellowship, meaning that the surgeons or the fellow were more independent doing these operations. So on average of around 15 to 25 mixed AVRs per fellow in the second half of the year, so a total of 130 cases. We did not have any conversions to sternotomy. We had no mortalities. We had 2 patients who had stroke. We had 1 patient who had renal failure, no surgical site infections. And our reoperation rate was quite high. It was 6%. Nobody wants to be reoperated, but fortunately, they were all because of intercostal bleeding. And these were really easily handled by just taking back the patient to the OR, cleaning up and washing out. We did not have any major bleeding. And obviously, this did not affect the length of stay of the patient. This is why we do it, because this is the most satisfying part of the surgery, and to see how soon the patients go back to their baseline. We always tell the patients to smile for the camera because obviously we want to show them in these conferences and show everyone that these procedures can be performed safely, and these patients actually return to work quite fast. Obviously, the picture was taken with the patient's permission. So now that you know how to do a mixed AVR, I'm going to talk to you about how to do an aorta and a hemiarch replacement through the same incision. And before you decide that this is too crazy, I'm going to show you that it's actually not that crazy at all. So these are some of the actual objections that people have. The exposure will be terrible. You can't do complex aortic work through a small incision. The clamp times are going to be ridiculous, and the conversion rate is high. And if things go wrong, you're stuck. I mean, it's very obvious. But the good thing is that sternotomy should not be taken as loss. A sternotomy is to protect the patient. So as long as everyone in the team knows that what you're doing is for the patient's benefit, I think it's easily digestible by the patient and by the team. So
sorry,
the setup
Dr.
is
Ziad,
everything.
Can I interrupt you for a second?
Of course.
All right. Sorry, it's an excellent presentation going on, and I don't want it to be rushed on or just getting over it, because it's interesting, and everyone is pretty keen to watch all of it and listen to you. We are having Friday prayers just in like 10 minutes. And would you mind if we reconvene after Friday prayers and you continue with the presentation?
Absolutely.
So that everyone can actually, watch this whole thing and then ask some questions as well?
Yes.
I'm really sorry I'm
Absolutely, no
interrupting you
problem
in
at all.
between, but the Friday prayers are just in like about 10 minutes.
No problem. Just let me know. Somebody can text me. I think Waqar has my number. You can text me,
Myself and Dr.
then
Waqar will
we'll
be
take it from there.
in touch with you, and we'll just disperse off for Friday prayers, and we'll request you to continue from the same point.
Absolutely, no problem at all.
Thank you.
Thank you.
Thank you.
Thank you.
So for the audience, the Friday prayers is at exactly at 12:45, and the mosque is right across the road. Okay, and